So, good morning, all. Thank you, Divya, and thank you, KSOS, for giving me this opportunity. So, today I will be dealing with the watering eyes, CNLDO, and beyond. So, as you know, the tear system is composed of two components, the secretory system and the drainage system. True epiphora refers to watering due to obstruction in the lacrimal outflow pathway, whereas hyperlacrimation is overproduction of tears. Any disorder that can irritate the cornea will lead to epiphora. This can be considered as pseudoepiphora. The causes include epiblepharon, congenital entropion, congenital glaucoma, allergic eye disease, keratitis, and uveitis. Embryologically, the lacrimal duct starts development at the age of 3 to 5 weeks of gestation. Canalization starts by 3 months of gestation and complete connection to nose by 8 months of gestation. So the fusion of maxillary process with the lateral nasal process results in the formation of nasolacrimal sulcus. The ectoderm separates from the surface and forms a solid epithelial coat which proliferates in the craniocaudal direction and later on undergoes apoptosis to form the lumen. Coming to the topic per se, CNLDO. In children, the most common cause of epiphora is congenital nasolacrimal duct obstruction, accounting for 20 to 30% of newborn. A typical cause of CNLDO is due to persistence of Hasner's membrane. Other causes may include bony abnormalities or narrowing of distal end of NLD. These are some of the syndromic associations of CNLDO. History taking is very important in case of pediatric epiphora, and this should include the onset, frequency, type, intermittency and laterality of the symptoms, and also any history of previous interventions. History of exacerbation during the episodes of upper respiratory infection point towards a functional stenosis, and also rule out any history of trauma to ocular adnexa or nose. Coming to clinical features, epiphora occurs within first 4 weeks of life. The classic clinical triad is epiphora, matting of flashes and mucopurulent discharge. So the evaluation should include macroscopic examination of the facial skeleton and also rule out any lid malpositions. Special attention to be directed to the sac area to rule out any swelling, skin discoloration or fistulas. Also note increased marginal tear film height. The most important maneuver is Rhoplus, compressing the lacrimal sac just behind the anterior lacrimal crest and expressing the contents out through the punctum. If Rhoplus is positive, a note should be made on the type of the material regurgitated, whether it is mucoid, mucopurulent or bloodstained. A positive test is a confirmatory test for NLD obstruction and no further diagnostic testing is usually necessary. Another most important test useful in children with epiphora is FDDT or fluorescein dye disappearance test. Here we can instill 2% of fluorescein into the conjunctival cul-de-sac. After 5 minutes there should not be any detectable fluorescein under blue light illumination. A positive test, or that is the retention of dye, indicates there is a dysfunction in the lacrimal outflow pathway, but it cannot find out the site of obstruction. So another important part of evaluation is ENT examination in the form of anterior rhinoscopy or nasal endoscopy to rule out intranasal pathologies such as intranasal cyst. Rare radiological investigations include lacrimal scintigraphy and CT dacrocystogram. Coming to NLD stenosis, depending upon the degree of stenosis, it can be either relative stenosis due to narrowing, which spontaneously improves as the child grows, or it can be absolute stenosis due to occlusion, or it can be a functional stenosis associated with rhinitis, which will cause nasal mucosal inflammation and subsides as the cold, and it spontaneously disappears as the cold subsides. These are the complications associated with CNLDO. So the most important part of management is conservative, that is massage of lacrimal sac, Krigler massage, hydrostatic pressure over the lacrimal sac area. The goal of massage is to force the fluid down to the NLD and cause the obstruction to open. So method of sac compression. So the parent should hold the baby in one hand with contralateral index or little finger. You have to just compress over the lacrimal sac area just inside the anterior lacrimal crest below the medial canthal tendon. And how frequently? 10 times per session with 4 sessions per day. That means 40 times per day. There is no need for downward stroke. So spontaneous resolution of CNLDO is attributed to the gradual maturation of NLD system, and our aim is to promote this natural resolution by applying gentle pressure over the lacrimal sac area. When performed properly, it plays a key role in reducing surgical interventions. So now the use of topical antibiotics should be minimized, indicated only when there is conjunctivitis or associated dacrocystitis. So the antibiotic eye drops carries the risk of bacterial resistance. A chronic bacterial infection at lacrimal sac level can cause fibrotic remodeling at the level of Hasner's membrane, and it will result in reduced treatment success. Coming to invasive procedures, probing. The timing of probing is always a topic of debate. Some recommend intervention until 1 year of age, whereas others recommend early probing, that is between 6 and 9 months of age, usually advocated in case of mucocele or dacrocele, or if babies are awaiting for any intraocular surgery like cataract surgery. So coming to technique of probing. So the punctum is dilated with a Nettleship punctum dilator. After that, appropriate site Bowman's probe is chosen, and it is passed first through the vertical canaliculae, then slightly give a lateral traction on the lid and pass it to the horizontal canaliculae until we get a hard stop. After that, rotate the probe 90 degree and align it parallel to the supraorbital notch. Then the probe is gently advanced into the nasolacrimal duct downwards, backwards and laterally. Mild popping sensation is felt when the probe penetrates the membrane. These are the different sizes of probe available for different age group. And here you can see as the number of zeros increases, the diameter of probe decreases. So the success rate of probing is reaching up to 90%. And if the symptoms recur, we can do probing after 4 to 6 weeks. And in cases where 2 probing attempts fail, further imaging modalities have to be done. Now, endoscopic assisted nasal probing has improved the success rate of NLD probing, minimizing the complications such as false passage and also nasal mucosal trauma. So with that, the CNLDO can be classified as simple and complex. Simple, the membranous obstruction can be overcome with minimal resistance. Complex can be again divided into incomplete and incomplete. In incomplete, the probe can be retrieved from the nose, and in complete, the probe cannot be passed into the nose. That means it is a bony obstruction. So coming to another invasive procedure, balloon dacroplasty. Here the goal is to dilate the distal part of the NLD using balloons. There are 2 sizes of balloons, 2 mm and 3 mm. So here the balloon is having 2 markings, that is 10 mm and 15 mm. So the balloon catheter is lubricated and passed into the lacrimal system until the 15 mm marks coincides with the upper punctum. Then 2 cycles of balloon inflation and deflation can be performed. The first cycle 8 atmosphere pressure of 90 seconds, followed by second cycle 8 atmosphere pressure of 60 seconds. Then the probe can be withdrawn to 10 mm mark, and again this is done to dilate the NLD. Now coming to silicone intubation. Silicone intubation is another invasive procedure, but the problem here is that the babies will need a second surgery for the removal of the tube. The last resort is dacrocystorhinostomy, especially useful in case of bony obstruction and complex cases. So it can be done either externally or endonasal wise. External preferably once the facial development is complete, and this reported success rates are reaching up to 96%. Endoscopic endonasal DCR has got advantage of like assessing the intranasal abnormalities as well, and precise visualization and management of obstruction. Now, a few words about dacroendoscopy. It is a procedure using microendoscopic technique to visualize the entire system, starting from the puncta to the inferior meatus. So we can accurately assess the type of inflammation, location of fibrotic tissues, as well as recanalization is possible. Now, some unusual congenital lacrimal disorders that can lead to epiphora. One is punctal agenesis. So here the treatment is conjunctival dacrocystorhinostomy. Another is incomplete punctal canalization, which refers to punctal distances with membranes. So here, puncturing the membrane with a punctum dilator will treat this condition. Then comes the dacrocystocele or amniotocele. So this presents as a bluish mass just below the medial canthus immediately after birth. So if there is no infection and no respiratory distress, it can be treated conservatively. If there is infection and respiratory distress, endoscopic removal of the cyst and probing is needed. So to conclude, knowledge of the various causes of FP4 as well as their therapeutic approaches enables effective treatment and delivers individualized care for pediatric population. Thank you.
Thank you, Dr. Naveena, for that very good presentation.